Okay, our next speaker or speakers is a duo of professionals. We have Mrs. Elissa Sarich speaking on obsessive compulsive disorder and Tourette's or tic behaviour spectrum. Yes? Oh, you're doing intervention. I'll let them introduce what they're doing because the title on here is the combination of the two. So Elissa will talk about her specific portion of that talk, to be followed with Dr. Yuria Furlong again. Thank you very much.
Thank you. Can you hear me? Yes? Thank you. We thought we'd break things up a little bit and start with talking about interventions, and I have a case example to present to you today to talk about how we actually embed some of the research and embed the evidence-based practice into what we do. So, as I was introduced, my name is Elissa Sarich. I'm a clinical psychologist at Perth Children's Hospital, and I work with Dr. Furlong in the consultation liaison program, and we liaise extensively through the hospital with various departments, and all our referrals are actually from ongoing patients of the hospital that we will then see. So if a neurologist or paediatrician refers through to us, that's how we receive our referrals. A bit of an introduction about me, but my curiosity and interest in tics and Tourette's came back when I commenced my career as a school psychologist, so working within schools and seeing students within schools, assisting with diagnosis, embedding strategies, liaising with school personnel. I then continued my training in clinical psychology and worked with children and adolescent mental health services in community clinics. I did spend a period of time at PMH and then have returned to the hospital again at Perth Children's Hospital. So a little bit about me. Today I'd like to talk about evidence-based interventions. We'll be looking at the importance of psychoeducation, behavioural therapy. We'll touch again on medications and talk also about alternative treatments that I'm sure you've heard about as well, and look specifically at talking through a case example, which we can then look to actually see how some of these interventions and models work. So what we've discussed this morning and Dr. Furlong went through, there are common motor and vocal tics, and any or all of them, some, one or multiple, can be involved with Tourette. So it's important to be clear in terms of the different forms of motor and vocal tics that can be involved. And this list is by no way an extensive list. Yeah. I did have a video to show, but I think we might skip that because we've had a couple of introductions in terms of Tourette's, and I have another one later on which I think will be beneficial to watch. So first of all, I'd like to talk on psychoeducation, and a lot of people who are not in psychology will often say, what do you mean by psychoeducation? And basically it's combining psychological theory and psychological knowledge and educating parents and either patients or clients and also educators and people in the community. So it's combining psychological knowledge and theory and educating. Psychoeducation should be provided at the beginning of all treatment. Further individual causal factors and options for treatment should also be discussed. So right from the beginning, taking an extensive history and background information in terms of what's involved for a client and a person and what has brought them to seek treatment. Psychoeducation involves providing detailed information to the relevant people. In the case of young people, this will usually involve parents and teachers, and information should be provided regarding the disorder, its course, investigations, and options for treatment. School liaison can involve facilitating regular school case conferences or telephone, email feedback and reviews. So right from the beginning, as you're gathering information and collecting, that consultation and liaison is really important to see, for each client, where is their presentation, how is it different, and what do we see in all of those different environments. Collaborating with school personnel to develop differentiated education plans, individual education plans, or educational support plans. So they're called different things in different schools, but basically it's about collating information and providing a detailed plan to assist to support students within school. As I said, consultation and liaison is important with medical and allied staff, in particular if speech and OT is involved. So through consultation liaison, providing information for teachers and school personnel, facilitating recommendations to support implementation of coping strategies. For example, allowing the child to sit an exam on their own or to be permitted to leave the classroom for short periods of time. This can assist with regulation and assist with lessening the urge to keep the tic in when they're in those situations.
Just in relation to the special consideration for the exams for children with Tourette's, sometimes a child could be allowed additional breaks, time for additional food, drink, and time to take medication. Just wanted to make it clear that there are guidelines in WA. If anyone is interested, I'm very happy to share those with you.
Thank you. So essentially it is assisting the child to help regulate, whether that is with medication, etc. The second point there too is in secondary school, the school's curriculum standards authority can assist with providing a structure for exams and the forms that you need to look for and speak with the school and your medical practitioners is the special exam conditions. And as Dr. Furlong said, you can look at various seating, positioning, break times, time to take medication, and the moderators will help to implement those strategies that are outlined. But your school personnel can help you to formulate that application. In cases of mild severity, taking into account the high rate of resolution of some tic behaviours, psychoeducation may be all that's required in terms of that consultation liaison and providing support and structures in place. And often it is a wait and see approach and keeping an eye on whether relapse prevention or reoccurrence occurs or comorbid disorders that may present. So looking at behavioural therapy, evidence-based research has found that the habit reversal technique, so stopping the premonitory urge, and relaxation therapy, which may reduce the stress that often exacerbates Tourette's disorder, are the main evidence-based therapeutic interventions. For older children, adolescents and adults, they often report tics to be preceded by an unpleasant sensation, denoted as the premonitory urge. In 1980, Bliss provided the first detailed account of a series of preliminary sensations that preceded or accompanied his motor and vocal tics. He described sensory signals preceding his tics along with a very rapid escalating desire to satisfy the sensation with movements intended to free oneself from the insistent feeling. And that's often the feedback that we get from people with tics and Tourette's, that they can often identify that urge and implement strategies to manage that. There is a scale that can be used to help identify and monitor those urges. I thought this was a lovely video of a boy who explains his Tourette's and how he uses music to help him manage those urges. Oh.
Hi, I'm Adam. Hey! Sorry. I'm Adam. I'm 16. And as you can tell, I have Tourette syndrome. I also have ADHD and OCD, but that's different. What I'm going to be doing today is because I'm ticking quite bad right now. I wanted to sing a song for you guys so I could show you guys the difference between what happens when I'm not singing. Shit! Fuck off! And when I do sing. So this is Superpowers, written by myself, which I hope you guys enjoy. Tables have turned, stakes are getting higher, but I am determined, I am on fire. Jumping from building to building, I'm gonna find ya. Mile after mile, I'm getting closer. Ain't got no lightning speed or x-ray vision. Don't got a spell to get ya out of prison, but I know that you are gonna wanna be next to me, baby, baby, baby. I'm gonna...
I could listen to him. Very talented young man, but I thought that was a great example of seeing how his tics were quite prominent and utilising that competing response really in terms of singing and playing music to manage his tics. So in summary, the gold standard of intervention is comprehensive behavioural intervention, which is often the shortened term is CBIT, which includes cognitive behavioural therapy such as habit reversal, education about tics and relaxation techniques. Massed competing response habit reversal practice has been one of the most frequently used behavioural therapy techniques, which includes deliberate repetition of a competing behaviour or an action to the tic at intervals, which I'll go into more detail when I present the case. But examples of this can be whisper reading. So you are talking at a normal volume here, and then if you're whisper reading, you are utilising a different part of your voice and a different part of your brain, which actually is a competing response to a tic, because you can't whisper and tic at the same time. Ball bouncing, eye widening, slow blinking are all examples of competing responses with eye tics or with arm movements. Contingency management is another behavioural treatment which is based on positive reinforcement and is usually administered by parents. So amplifying and rewarding positive coping and implementation of strategies. So really that's a fancy way of saying the fantastic support that parents give in managing their young person. Self-monitoring is very important. This is where the patient records tics by using either a risk counter or a small notebook. It's fairly effective in reducing some tics by increasing the child's awareness and prompting motivation to practice competing response exercises. Again, I'll go into a little more detail in my case example. Cognitive therapy is introducing flexibility into rigid thinking, and confronting the child's irrational expectations and unrealistic anticipations. So really looking at what the thoughts and thought processes are around how a child feels and comprehends why they're ticking. Distraction has been shown to help patients resist sensory urges and to restore the patient's sense of control over the tic. Other treatments include occupational therapy to develop self-care, play, learning activities, and increase independence in functioning. This can be facilitated through sensory integration activities, teaching regulation, psychological counselling, support groups, and biofeedback with limited results. So sensory treatment and self-regulation skill building has been successfully incorporated in a multidisciplinary approach through Westmead Hospital. And I had the privilege of meeting with a number of clinicians, one in particular, Chris Hardwick, who's a clinical psychologist at Westmead Hospital in Sydney, and he coordinates a program at the Westmead Hospital in utilising an adaptation of the ALERT program in working with children with tics disorder. So I'd like to acknowledge him and the work that he's doing, because I was fortunate to meet with him and talk with him about the work that he does, so that we can also look to implement that here in WA. That's a copy of his draft research paper, and I could certainly pass that on to anybody who's interested. But the outcomes were very positive in terms of integrating regulation into therapy. So the ALERT program, which I've alluded to, I'm not sure if many people have heard of the ALERT program. It was developed in 1996 by two occupational therapists, and they were focusing on self-regulation, which is the ability to attain, maintain or change how alert one feels appropriate for a task or situation. Visually, and you can tell this was 1996 because of the computer. But basically, it's what we see, hear, touch, taste, smell. It gets inputted, how we attend to it, demonstrate knowledge, learn, interact with others, interact with the environment, how we move, our esteem, our self-control, our feelings, which all then feeds back into how we can regulate our system and how we can adjust to our behaviour in various situations. Another visual for you, obviously I work with kids, so I try and utilise what they're interested in, and for a young boy that I worked with, he was very interested in cars, and we were able to discuss his engine speed. So to use the analogy of his body like a car engine, sometimes you may feel like your engine is running high, so too fast, or sometimes it's too slow. At other times it is just right, and to congratulate yourself that you are working and travelling at the speed limit. You've decided you can check your engine, you can look for clues, you can chart your speed, and you can make changes if necessary. And even being able to have a checklist and formulate a list with kids of what strategies they can put in place, so when they're noticing their engine is running too high, what they can do. If their engine is running too slow, what they can do. Or how they can get that acknowledgement that they are running just right and at the speed limit. Of course, this all helps and can't be done without the consultation and liaison with classroom teachers, educational assistants, working with OT if you have the access, working with clinicians to assist to put that in place. Another program is called Zones of Regulation. And in Zones of Regulation, you're teaching various vocabulary and extending emotional vocabulary. I can see a few people nodding that they've obviously come across zones of regulation. But it's a great program also that can be incorporated not only in the classroom, at home, in various sporting situations, extracurricular, and it's teaching people, a similar language that can be used and incorporated through therapy. So to give some examples, you're looking at widening the vocabulary, expanding vocabulary for everybody so that for a child they can link in with what zone they're in rather than trying to find the words to describe how they're feeling. And utilising various ways of communicating what zone they're in and increasing that communication between classroom personnel or coaches to help facilitate that. It also puts in perspective and teaches what is the size of the problem that we're looking at. Is this a big issue or a small issue? Is this something that we need to attend with right now, or is this something that we can hold on to and discuss later?
Just to come back to the medication, just to cover it a little bit in more detail today, and I very much welcome questions from the audience as well on that topic. As we explained as I explained in the previous talk, we do not consider medication as a first step for Tourette's, but it is acknowledged that it's a very useful intervention for tic disorders. We have already highlighted the usefulness of alpha-2 agonists, guanfacine and clonidine. From my perspective, I've found, clonidine, we have a lot of predictability working with this medication, while in itself it's not it's very specifically designed for tics. It's a medication for blood pressure, and it's probably not as sophisticated as some of the other options, but when we're looking at an agent that is reasonably benign, that we could monitor carefully in relation to, for example, if someone comes off that medication, you could have a rebound hypertension, so we have to make sure that doesn't happen. But other than that, it's usually well tolerated. The guanfacine is a very new medication. It has another name, Intunif, and I would say that we just don't know enough of how young people respond to it. I do believe that it's useful for ADHD, but I don't have a good data to present definitively that there have been large enough samples studied with Tourette's benefiting from it. There is a lot of variation in individual response. A lot of young people find the medication quite sedating, but it's very, very useful as an adjunct treatment for ADHD. For example, if a child is on the stimulant in the morning, but the symptoms return in the second part of the day, it could be administered in the evening time. Again, I find we're only beginning to use that. The atypical antipsychotics that have been used extensively for young people involve the risperidone and aripiprazole as a sort of main agents. Sometimes we use quetiapine, which is another mood stabilizer, stroke antipsychotic medication. With risperidone, the biggest problem is the adverse side effect profile with sedation and also with hyperprolactinemia. So this is a troubling side effect for youngsters. So it's obviously affect the hormonal function, and that's where there might be a consideration against it. But sometimes with risperidone, Another problem is tolerance. It does work for a number of months, and then suddenly it would stop working. So none of those medications are foolproof and ideal. Aripiprazole, I want to say specifically, I have been using more, and in the case that we present, we have achieved some successes with it. As you know, you may know that it also has a license for autism, for children with irritability who have neurodevelopmental disorders such as autism. So what we find is that it's that indication for the intense emotional responses, for the impulse control. That's what we're treating really. Again, are we treating tics or Tourette's? I don't think, because, as I explained to you, all the neurocircuits there, it's unlikely to have a direct benefit, but it's a good symptomatic relief that allows, for example, for Elissa's therapy then to benefit the young person. So it's about stabilizing irritability, impulse control issues, and also aripiprazole is more favorable to risperidone in the sense of less of a sedation. So it could be given in the morning, so like even for children who go to school. So it has that benefit, and the weight gain is less of a problem than for risperidone, although it still could cause that. Just the haloperidol and pimozide, I haven't used in children. It is used in adults, but again, back 1960, there should be a lot more progress since then. You can imagine, because it caused the blockade of D2 receptors, you have a lot of adverse side effects, such as, potentially depression, and then the movement disorders, the non-voluntary, involuntary movement disorders that, could potentially make tics worse as well. So it's a hard one to recommend from me. And then the tetrabenazine, I have mentioned already, it's been recently licensed for Huntington's. Again, they talk about symptomatic function, not acute, like curative function from that. And it has been effective for those young people who didn't benefit from anything else. So it's a kind of like a very last resort medication, and then it's not available that readily in all the jurisdictions. So personally, I haven't used it, but there have been very interesting case studies, and maybe the neurologists use it more. And then antiepileptics, topiramate is the one that has most studies, and in small dose, it's helpful for Tourette's and also for ADHD. But topiramate also comes with a worry inside profile in relation to cognitive functioning, and it could slow down the processing speed and working memory in kids. So there are a lot of other antiepileptics that could be chosen by a specialist, that, for example, lamotrigine for mood stabilizing effect. They're not specifically mentioned in the literature, and this is very recent review by Blackburn 2018, but it doesn't stop us, choosing the right medication for your child. If with all our expertise, we might choose the one that isn't listed on that list if we feel that there are symptoms that could benefit from it. Alternative treatments then, again, like a physical, like the, some of the other, like alternative treatment and interventions, there is no evidence to support the effectiveness, but I have spoken to some of you during the break, and, as I said, for young people who are older, in some cases, the various like TMS treatments, DBS treatments have been used, and I could explain the evidence for them, but I think it's probably for another talk. But certainly, none of the guidelines supported the safety of those interventions for children. I might just let physical activity.
That's, so there is some anecdotal evidence which exists regarding the benefits of physical activity. So rhythmic type sports such as swimming, when you have the cross body, utilising both arms and legs and cross body, which assists. Patients should be informed and encouraged accordingly. There's no evidence that diet, vitamins or mineral supplements alone are of benefit, but of course should be discussed in conjunction with overall health and well-being. Of course, you know, we're looking at promoting the growth and development of children and young people, and even maintaining health as an adult. So all in conjunction, obviously, with overall health and well-being, but studies have shown that alone they don't provide specific benefits. So the evidence does show that habit reversal therapy, or CBIT, is effective, but there's no evidence that that alone, relatively to combining medication. So as Dr. Furlong has said, when we combine the cognitive behavioural therapies with medication, that's when we see the best outcomes. And often that's because of so many different comorbidities that are occurring. So I'd like to move on to talk about a case example, and as I do that, I'm not bribing you all, I just thought this would be a good exercise. If you'd like to take one and pass it on, but don't eat it straight away. Okay, so everyone will get a minty, but if you take one and pass it on, so as I'm giving some information, we'll come back to the minty through my talk. Hopefully I have enough, but there is another packet if we find we need to. So the case example, and I'd like to start with referral information. This is a 13-year-old boy with a history of vocal and motor tics for 5 years. He had emerging obsessive compulsive behaviours and a previous assessment of ADHD, but at the time of his assessment he didn't meet criteria. Investigation and review through neurology at Perth Children's Hospital had occurred, and it was found that there was no organic cause for his tics or behaviours, so he was a healthy young boy and was referred through to PCLP, so our consultation liaison department, to assist. The family had sought previous intervention through community CAMS, which is Children and Adolescent Mental Health Service, but they had reported that there was no improvement at that time. He had previously been prescribed fluoxetine, risperidone and clonidine with limited improvement. So after assessment, we found our provisional diagnosis was combined vocal and motor tic disorder, which is termed Tourette syndrome, with obsessive compulsive behaviours. So my initial formulation was a 13-year-old Sri Lankan boy with a presentation of severe Tourette syndrome and significant functional impact secondary to frequent intrusive vocal and motor tics for 5+ years. And there were emerging repetitive cleaning behaviours. Predisposing factors included psychosocial history of early migration, so he was 4 years old when he came to Australia. He didn't know English when he commenced kindergarten, and a difficult relationship with his Year 2 primary school teacher, which was reported by his parents. Precipitating factors involved, there were no specific factors that we could ascertain, although ongoing social pressures, reduced attendance and compliance at school were maintaining factors. Severity of tics increased his vulnerability due to risk of self-harm because he was hitting and scratching himself, as well as increased helplessness and hopelessness about how he felt. And the vulnerability risk factors also included increased social isolation, and he was at educational risk because he couldn't attend school and had difficulties attending in class. Protective factors included supportive, intact family and a school who have implemented safety plans to reduce risk of accidental harm and student services support. Individual and family willingness for treatment and ongoing support and follow-up was also very good. So when we looked at our management plan, our first port of call, as you heard me say earlier, was psychoeducation, so provision of information about Tourette's, focusing specifically on improving his adherence to treatment and compliance. I wanted to hear what he'd done before, what he'd tried, what had worked, what hadn't worked and why, because that was important going into our therapeutic relationship, because I didn't want him to feel like I've done that, I've tried that, and I haven't got the energy to keep going again. So we developed the plan together. What was he willing to work on and what was he willing to try again? Then came step 2, which was the monitoring, which is a really important step in intervention because we're building awareness about what's going on. Here I want you to take your minty. Has everyone got a minty? Oh, people have already started to have their minty. Does anyone need another one for the exercise? Yes? Yeah. Self-regulation. No? Okay. So I wanted to demonstrate this exercise in terms of building an awareness. Okay, so take the minty. In your hands, just feel what the wrapper feels like. Okay, is it rough or is it smooth? Is it waxy or is it papery? Okay, now start to undo the wrapper. Is it tight or is it loose? Is it hard? Is it soft? So just focusing on those sensations. Opening up the minty. Just smell. What does it smell like? Minty. But let me take your focus. Can you smell the sugar? Yeah? Can you smell the salt? Is there anything else that you notice? Just take note of what you notice. Yeah? Now just have a lick. What are the sensations that you get on your tongue? Is it pleasant? Some people don't like mint. Some people will sneeze or cough with mint. Yeah? What is that feedback for you? For your experiences, past or present? For your experiences here and now after you've had morning tea? Oh, great, I get to have a mint to freshen my breath. Or am I feeling low in sugar and I need a pep up? Yeah? So what are you noticing when you have it? Then when you put it in your mouth, what are the sensations in your mouth and what can you taste? Again, the sweetness, the saltiness. Some people find that their saliva glands at the back of their mouth are activated, some at the front, some at the sides, some salivate more, some salivate less. Yeah? We are all individual. Our mouths, our tongues are all individual. Our experiences are all individual. And this can impact then what we're noticing in our body. And that's what we want to incorporate in this beginning stages of formulating intervention in building awareness of what's happening in the person's body. What are the thought processes that are happening? Oh yes, yum, I love minties. Or, oh no, I don't want to do this. Or I don't like this. Or it doesn't taste good. Yeah? So it's the collection of baseline data and continual feedback provided through data collection, either plotting on a graph or some form of visual of what we're doing. For this young boy, we used a star chart. He likes SpongeBob SquarePants, so that's what we put on the chart. And we adapted it to incorporate when he was going to monitor. So in the beginning, we chose first thing in the morning, mid-morning, lunchtime, mid-afternoon, evening. Yeah, because he stated they're the periods of time that he finds that his behaviours escalate. Yeah. As we moved through intervention, and you'll see from the graphs, that he found that labour intensive, and when we transitioned him back to school, it was a lot harder to do his tick monitoring when he was at school. That's fine. We reduced that. Yeah. But we had built the awareness of what he was looking for and what he was tuning into. So in the beginning, this is what his tick chart looked like. He was ticking nearly 40 ticks a minute. So he was only recording for 1 minute, and it was any tick, whether it was a vocal tick, a motor tick, yeah, any tick, he was counting. And you'll see here that it was morning, mid-morning, lunchtime, afternoon. So this was before intervention, and then as we implemented medication and competing response practice, he was recording the difference that it was making. The benefit for me was during maths, he was also doing graphing. Fantastic. Again, incorporate what is happening in the classroom, at home. So one of his homework tasks was to plot what he was doing and plot his monitoring. And he came back the next week and said, wow, there's such a difference between before I practice my competing response and after. And he could see that and plot that. I'll let Dr. Furlong talk about the medication.
So we had some ideas about how we would like to rationalize medication for our patient. First of all, I want to say that we didn't talk about antidepressants in our little slides about medication. Why that is? Because the antidepressant, specifically SSRIs, the selective serotonin reuptake inhibitors such as fluoxetine and sertraline, I used to treat the comorbidities. So it used to treat the comorbid obsessive compulsive disorder or any other anxiety disorders. But there is anecdotal evidence that sometimes, if the child is really, really young, it's also a good first step in our thinking of choosing that medication, because with addition of antidepressant, the quality of life improves, and sometimes tics also improve, because we know that link with anxiety is so strong. So that's why we haven't talked about antidepressant yet. So he was already on 30 milligram of fluoxetine, and or he was on 20, I think, milligram, and he came to us, and we've probably maxed out to see if it will give additional benefit. But I think all along we were hoping to rationalize and switch to sertraline, which I think we've done by now, and we've seen some further improvement. The reason why he's on 2 different antipsychotics is because, again, we started reducing risperidone gradually, and we couldn't just stop one and start the other. We were doing this very careful, very gradual crossover of medication because of the severity of his presentation. As you see, the clonidine has been used morning and night. So the 50 micrograms in the morning and 100 micrograms at night. I remember that at other times, maybe previously, he also needed to use some medication in school. So he needed to use additional clonidine in school at lunchtime. So, you know, I suppose this is quite a high dose of aripiprazole, 10 milligrams at night. So we've started with 5 milligram and gradually brought him up to the 10 milligram level. But this would be probably as reasonable therapeutic dose we would use for someone age 13. As you could probably saw in the graphs, you know, his tics have subsided quite significantly. So instead of 40 tics a day, he had maybe, a minute, 40 tics a minute. He only had about 10. So that's a huge improvement. That's a 75% improvement. So, yeah, that's just to explain about the rationalization medication of this case.
So moving on to the behavioural therapy that we implemented. So remember, CBIT includes cognitive behavioural therapy such as habit reversal, education about tics, and teaching relaxation techniques. So competing response or habit reversal practice was introduced and specific behaviours were developed collaboratively. Again, it's utilising what the person is interested in, what they have an interest in, what they're able to do, and perhaps what they've done previously and would like to come back to. And it's the deliberate repetition of a competing behaviour or action to the tic at intervals. Okay, so you're practicing a certain behaviour like you would if you were learning a new skill, yeah, and repetitively practicing it. So for this young boy, he found that his vocal tics were the most intrusive. So we introduced whisper reading and controlled breathing. Progressive muscle relaxation was also taught. And in fact, he brought in his yo-yo, ball bouncing, and hula hoop practice. Yeah? Not all at once. These were all behaviours that were introduced either weekly or fortnightly, that he had practiced a certain behaviour, and then he came in and he'd say, Elissa, I was thinking my sister got a hula hoop for Christmas, and I find when I'm doing the hula hoop, yeah, that I'm not ticking. Fantastic. Let's use that this week as you're competing your response. So he would measure for a minute how many tics, then he would do the competing response for a minute, and then he would measure for a minute the difference. Yeah? What I found and what I find with young people is once they find something that helps them and works, they want to keep doing it. So I didn't have to say to him, now I want you to practice this 5 times a day. He was motivated to do it anyway because he could see the difference that it makes. He could feel the difference that it makes because we had built that awareness and incorporating, building in and teaching him that self-regulation. Hey, it works. You're a detective and you found that that made a difference. So let's keep doing it. And then he'd come back the next week and say, you'll never guess what? I was using the yo-yo the other day and that worked. And I'd question him, why do you think it works? And he'd say, because when I'm using the yo-yo, I can't tick and yo-yo at the same time. You can tick before, you can tick after, but not at the same time. Yeah? Because you're focusing on that behaviour. Same with ball bouncing. Yeah, he was very keen to get back into the cricket program at school, to be able to play cricket at recess and lunchtime, working towards going back into community cricket. So he wanted to increase his ball-eye coordination. So we just started with ball bouncing. Yeah, you get a $1 ball from the shop, or the $2 ball from the $2 shop, and he was bouncing against a wall. Again, when you're bouncing a ball, throwing and catching, you can tick before, you can tick after, but you can't tick at the same time. Yeah? So he's practicing that event. Again, it's that rhythmical nature that also helps. Yeah? So the reward and feedback was that visual feedback that those homework tasks were having a positive effect. Yeah, even in teaching the progressive muscle relaxation, we would finish the exercise, he'd take a deep breath and he'd go, oh, I feel so much better. Yeah? And I would amplify that. I would reiterate that. Where do you feel better? Why do you think you feel better? When do you think you can utilise this? When do you think you can do that in your day? Yeah? He chooses to do it before he goes to bed at night. Yeah? To help regulate and to calm himself before he goes to bed. Whisper reading, he's actually found that he can utilise that wherever he is. If he is in the classroom and he finds that his vocal tics escalate, he goes back to whisper reading and he will just read whatever he can see in front of him, whether it's a sign, whether it's a piece of paper. Yeah? Going back to that competing response. We also negotiated rewards. He loved being on the computer. He loves gaming. Yeah, there's always weekly conversations about how much time can I have on the computer. There's daily and hourly conversations with his parents about how much time to have on the computer. We negotiated 45 minutes a day only. We put a timer on. He could stop the timer, go do something else and come back to it, but a maximum of 45 minutes. At some points we did deviate. It was school holidays, you get to do an hour, 2 hours, but he was monitoring and he could see the difference that it made to him. Yeah, and in therapy coming back and we would have a look at the spikes and what had happened. Oh, what happened there? And his mum or dad would say, yes, he spent 4 hours on the computer. So what happened afterwards? His tics would escalate. Yeah? Which, causal direct correlation, we'd have to do more studies, but for him, it was having an impact. So it's important to pick what's interesting and relevant to each child, yeah? For those that are not interested in gaming, then time on the computer isn't relevant. For others, it can be, going to the beach, going and doing something, an activity, or being able to have time doing something that they enjoy. So to date, in monitoring, we kind of got to a point here where he was starting to become a bit fatigued in monitoring all the time. And, end of year, school holidays happen, yep, go and enjoy yourself, go on holidays. And then he would come back in and say, oh, I've noticed my tics have escalated again. Okay, what do you think we need to do? And 99% of the time, he'd say, I need to go back to my monitor and I need to go back to implementing my strategies again. And this is while we are also adjusting medications and adjusting what his needs are. So looking at therapeutic goals, at the commencement of therapy, the patient could not tolerate leaving the house and found it very uncomfortable to sit in public, like the clinic waiting area. The first time that I met him, I could hear him before I could see him, yeah? And I know that that is such a big stress for so many of our children that we see. He would remove himself away from people due to the frequency and volume of his tics, and his goal was to attend regular appointments and complete homework tasks. Our next goal was to reduce vocal and motor tic frequency. He wanted to focus on vocal first, and then we identified the motor tics and he incorporated the competing responses. He was rarely attending school and could not go to shopping malls or movie theatres, which he reported to be having the biggest impact on his functioning. So his goal was graded re-entry back to school and increase to full-day school attendance. He was also spending up to 1.5 hours for each event in the bathroom washing each day. And we only found that that was occurring through him coming and monitoring his behaviour and exploring what was going on before, what was going on after. So that we then started to look at incorporating a goal of reducing the time in the bathroom. Therapeutic gains. He currently attends regular fortnightly appointments at Perth Children's Hospital and can comfortably sit in the waiting area. I now can't hear him before I see him, and he's sitting with everybody else waiting for his appointment. He attends school full-time, and he has an allocation of a pass-out card to attend the Student Services Support area where he can sit and regulate before re-entering class if needed. Over the summer and Easter holidays, he successfully went shopping with his family to the local mall, and he assists with food shopping. He's now able to attend movie theatre and enjoy new release movies. He said, "I'm sick of watching movies that have been out for 5 years already. I want to go to the movie theatre and see Toy Story when it premieres, not wait until it's out on DVD." The bathroom washing has reduced to 30 minutes for each event, and we've implemented a timer and an agreement on that. We place the timer in the bathroom, and he maintains awareness of his cleaning tasks while in the bathroom. Because what was happening is he was mindlessly, going into the bathroom to wash and shower, and then he'd think, "Oh, where am I? Have I washed that? Now I need to go back to the beginning," which is where you see that obsessive compulsive loop start to kick in. But because we had raised his awareness and his mindfulness in terms of doing events, when he goes into the bathroom, he grounds himself and thinks, "What am I going in to do? These are the things that I'm going in to do. Here's the timer to remind me that it's 30 minutes and time to get out." And then Mum and Dad are not always banging on the door and giving so many reminders. Mum will give some reminders, but that was causing conflict in their relationship also. We're continuing to review and monitor medications. We're continuing to develop and implement competing responses and habit reversal intervention opportunities. And now we're at the stage where he brings them in. This is what I've thought of. This is what I have. Has a fantastic imagination, and he is in his own world. He knows what he has access to, and he knows what interests him. I am just there to provide that, vehicle to explore and identify what that is with him. We have recommenced monitoring of tics and maintenance of awareness due to, the lapse in when he's not doing it, he finds that the tics escalate. Of course, there's been more tests. He's had NAPLAN. He's had end-of-term fatigue and stress. He's now attending school full-time, which over a period of a week is fatiguing. So that is going to also contribute. And this is where that psychoeducation is really important all the way through therapy to build that understanding of what's happening so that we can continue to problem solve and work through what's going to help in terms of his progress. So now we're developing maintenance skills and coping strategies to facilitate his own individual management. We've started to space out his appointments to 3 weekly, even monthly. And the family knows that if things escalate, they can ring to have an appointment to bring it forward if they find that things have ballooned out. But what we're finding is we can now move to monthly appointments because the family as a whole unit can problem solve together in terms of implementing strategies, and the continual consultation liaison between school, home, therapy are all speaking with each other and moving in the same direction. So thank you. They're my details. If anybody wants to contact me to find further information, and I'll pass on to Dr. Furlong to finish off.
I just wanted to comment that some of the curative factors in this case, I think you probably already guessed, was the fact that Elissa was able to contain the situation, but she was also able to form working therapeutic relationship with the client, because asking someone to complete a form 4 times a day, you need to have that relationship, you need to have that buy-in that links to the therapeutic factors in the therapist. So when we're saying this is a very specialized field, Tourette's, there's also a generic therapeutic factors that are at play. And if you look at 300 talking therapists, when they're trying to find what is it that's the most important, it's usually that relationship. So I just wanted to make that very explicit. Look, our other slides, and I think I'm afraid we've run out of time.
He was there, but he's left.
Oh, yeah, so he's left. I don't think Dr. Silva was here. Oh, good. Okay, no problem. So the little bit of what we haven't talked about is what's the future research for us, and maybe that would allow me to come back to that, unusual surgical procedures, that you might have seen on the YouTubes, and it is a very valid treatment, because a couple of you asked me in the break about this treatment. So I just wanted to give you a bit of history. So as with other neurological conditions such as intention tremor or the Parkinson's disease, there have been a treatment called DBS, deep brain stimulation, that has been for some time now. But when it came into practice, there have been a lot of maybe practical issues, mistakes that were made. When it comes to the area of Tourette's, those issues have been already worked out, and there are quite a prolific European groups in Netherlands and in Milan, as well as the Case Western Reserve University in Cleveland, Ohio, that specifically put a lot of their thinking into how the DBS could help people with Tourette's. The background of that is that the idea of DBS, or the deep brain stimulation, is to interrupt cortical and subcortical circuits, for example, the basal ganglia circuits that we think are responsible for perpetuating of symptoms that we see in movement disorders, such as the essential tremor and Parkinson's. And so the entities within movement disorders have been carefully studied. And they're born out of notion that instead of putting a permanent lesion in the brain that would also trespass the areas surrounding the lesion and have much wider surgery, the DBS is a more sparing technique that works a little bit like a pacemaker, where you could actually tune it to an individual and control the symptoms without the adverse effects of medication, for example. So in a way, it could cure a very severe cases of Tourette's. And what we've seen, I don't know if you had a chance to see it ever on the YouTube, it's usually the American media channels that we actually learn about those cases. It's usually a very, very severe cases where someone's quality of life is really, really impaired, and suddenly they can't, they tick even more than 40 times a minute, they can't function, and suddenly with this DBS they function, they could speak and go about their lives. So it's a very, very interesting time that is being discussed. One question that was posed is around, is there placebo effect? Because if someone has agreed to the open brain surgery, when they went through all of that, they have to make the fund of their folly in a way. They have to somehow feel it wasn't for nothing. So that was one question that was asked. But that's why now all the centers who practice DBS, they combine their efforts in a consortium. So when we get information, we get a regulated information that's maybe closer to what the effect is of this treatment. But certainly I'm intrigued about it. I could see the rationale from a neuroscience base in relation to it. So I think, I'm obviously not saying that it is for children yet, but, it's an interesting new perspective to look at. So the other, I suppose, various trials that are out there, it's really that we're looking at various outcome studies. We're looking at randomized control trials for certain medication. I have mentioned the, other study that was done in Yale University looking at NAC, which is used for example, for paracetamol overdose treatment. So it's a natural substance, and it's something that could be bought as a supplement. They have done various studies on tics, and they found that no randomized control trials. Unfortunately, it's not effective, but it's effective for trichotillomania. So that is something that we do need to follow up. So NAC stands for N-acetyl, acetylcysteine. So it's a kind of like amino acid, and it has a very wide health implication. I just wanted to bring your attention because this is a sort of a very specialized. So when clinicians practice and they've tried everything, all the 10 medications that are approved, they're looking for that silver lining in the substance that are hopefully benign, and this one seems to be hopeful. So while the randomized control trial hasn't proven its effectiveness, I'm still aware of several clinicians trying to use that as an adjunct for treatment of Tourette's. In terms of how do you combine then the medication when you have the comorbidity? I think that's what I usually ask the most questions about, and it's a tightrope, because, as we just mentioned, the stimulants are very, very effective when you find the right one for your child. And even, I know that Wei Chan is not here, but talking about the ADHD, there is a new knowledge that if you look at the whole sample of ADHD kids, 30% would respond just to dexamphetamines, another 30% just to methylphenidate, and the next 30% to both, and 10% to nothing. So in a way, that's how complicated this task is. And then you have additional task of making sure that the tics are not worsened by your treatment of ADHD. And that's where my point about having team of specialists that, working together and able to collaborate. What we're lacking in Western Australia is actually clinical psychology service for young people. We are absolutely, I know that Elissa works in public service, and I have been asking her to move on to private, but it's not possible yet for her. But I'm just saying we are desperate, and we would like to send this message out to other practitioners in clinical psychology. This is a area of need that's growing, because we're now able to recognize the problem better. We know that it's not 1 in 20,000, it's 1 in 1,000 that's been affected by this condition. So we do need to maybe And that's why, that's how we're using the epidemiological data for service delivery. That's how we're trying to, get some idea what is the service needs are. And not everyone is entitled, unfortunately, to services in Perth Children's, which I have answered a couple of questions at the break, that, Perth Children's Hospital is for young people who present to the hospital due to other chronic conditions, chronic medical conditions. Then they're entitled to the service to us. And, for this case, for example, there was, it was kind of probably more rare case where the child mainly had Tourette's, but I think there was also a lot of neurological investigation. I think they thought maybe it was epilepsy because of the severity of tics. So I know it's not a very reassuring message, but I think, remember, 1972, America, association like you have achieved everything, because then it started with the DSM-3 when they looked at what is this condition in DSM-3 in American classification. Finally, they were able to differentiate between different tic disorders, and then they also said that now we need services, so they're advocating for services. So I think a little bit like this, what's needed here, and I think just want to emphasize how important this meeting has been for everyone, and seeing the health professionals among the attendees is also, very useful, because we could network and we could try to share that common knowledge. And you mentioned there was a question online. I'm just going to read out a question from Wendy. Risperidone and hormones, would you consider physical growth stalling being on the first percentile a possible side effect? Look, that's very difficult for me to answer, I'll be honest, because, as psychiatrists, we deal with monoamines and we are quite narrow in our understanding of metabolic issues. But I would certainly think that, with risperidone, there is a lot of evidence that it's not an optimal choice of medication for a lot of youngsters. So could it impinge on development? Absolutely, but we also need to understand, is this child on stimulant? Could that be another drug interaction that we, might be missing in the description of that question? Because, on the stimulants in the whole, maybe if you think that someone was started on stimulants at the age of 6, by the age of 18, they could potentially lose 1 centimeter in height. So when we're talking about developmental trajectory, that's relatively small things. I mean, 1 percentile, that's already a child who's very vulnerable, I feel, in their developmental pathway. But I do think there are probably better people in the room to answer that. So sorry, I wasn't able to grasp the whole thing.
That's all right. I've got another one that's come through just now. There's been a rising interest in a dental device that reduces tics. What is known about this? So that would be the TMJ. I don't know if you've heard about much of that.
Yeah, look, we had a recent presentation from America around the use of TMS and, the various other similar devices. It's definitely something that we're exploring, and maybe not so much to answer the question directly, because I haven't had a chance to see that in operation. When we ask physiologists, why do you want to put a stimulator in someone's brain who already has excitatory condition, this hyperkinetic component? And the answer to that is that before we thought no stimulus is better than abnormal stimulus. Now we don't think so any longer. What we want is the, increased stimulus to the area of regulation of the right circuit. So we are kind of much more advanced. Some of these machines maybe work more on what Elissa described, like a biofeedback. So if you remember this whole thing, it increases that loop and help the child to calm down and reinforce some of the positive strategies, it might be an excellent idea. It doesn't sound invasive. So I would like to know more about that. Thank you.
Thank you. Has anyone in the room got some questions? We've got a little bit of time before lunch.
I'd really like to ask a question. I'm not sure if anybody in here can answer it. When Kayla was, sorry. Hello. So when Kayla was 15, she got really sick. This was after an immunisation that she'd had. Within 2 weeks, she was bedbound, couldn't walk, was in chronic pain all the time, was sleeping up to 24 hours a day, sometimes only getting up for an hour at a time and then going back to bed. Now, it was after that that I noticed it started. And this was like, they originally thought it was epilepsy. They thought it was myoclonic epilepsy because they could see epileptic activity on her EEG. And it took years for us to find out that that wasn't the case and that all of this was a tic disorder, which turned out to become Tourette's once they took her off the epileptic medication. But no one has ever been able to tell us why she has this pain in her legs. The neurologist thinks it's possibly because she was born 3 months prem and she sustained some brain damage, that all of this is here, but we've never had a concrete diagnosis for her legs or a reason why. And would any of the brain damage be related to why she has Tourette's now? That's a couple of questions, I suppose, I've just posed to you.
Yeah. Look, without going into the full medical file, I suppose the question for me would be, when we're trying to look at the diagnostic guidelines for Tourette's, we also have to meet the criteria that it's not due to other condition. So I would be very curious to know about that other condition, especially that the age of onset of symptoms was atypical for a childhood onset Tourette's. The other question I would ask is obviously, is there an obsessive compulsive component that, may be explained through pandas and, some other things linked to infection. I would probably ask about familial history, including the autoimmune disorder in mom and, obviously intrauterine and developmental questions that I don't think we should go into the whole thing here, but I think it is about reassessing things and trying to be very specific, why in this case it was a kind of different presentation. But certainly like with pandas, we have much more understanding of it. It is linked to streptococcal infection, and we think that it's very much is a reason for some of the later presentation of OCD and tics in young people. So that's worth exploring further.
She did have tics when she was younger, just not really noticeable.
Okay, so maybe that.
She had, her comorbids were probably more prevalent when she was younger. She was diagnosed with anxiety and depression at 5. And she's always had some OCD tendencies anyway.
But that still, there was a very important historical infection that you described that was quite debilitating. So I would probably need to still go back there and try to elucidate if, there were other deterioration.
We've been told mitochondrial disease, autoimmune disease. There's nothing in the blood cells.
I think I'm going to ask Dr. Shah, who's a neurologist, to help you. Thanks so much.
So when we see a new onset of tic in neurology clinic, we do rule out secondary metabolic and neurodegenerative disorder, along with mitochondrial copper disorder and disorder.
Yeah.
And top of that, you do streptococcal serology. So those are the baseline tests we do see for a first new onset tic, so that we are not missing secondary tic disorder.
Yeah.
So they must have done that to rule it out.
Mitochondrial disease, but we never got to have any tests done. Kind of just got pushed to the side there. And because we have a lot of, in our family, the neurologist who mentioned mitochondrial disease said that the ducks line up, he said to me.
I think
all
the
mitochondrial family history of different things and the way Kayla.
So, and mitochondrial disorder is, but it's one a very rare cause of the tic disorder.
Yeah,
I mean,
she has lots of other medical issues as well.
yeah, so and sometimes we see a rare presentation of Wilson's or things like that. So we do have a baseline tick boxes we do it before, we should put it as primary tic disorder.
Thank you so much. Thanks, Dr. Shah. Anyone else want to ask a question? Yes, please.
Yeah,
I have a son who has Tourette's, and I think it could be so many reasons why, as we have learned today, with maybe genetic or so. And interestingly enough, my mum has just been diagnosed with SLE, so I'm very interested to hear more about this autoimmune connection. But what has worried me about my son is that, and also it was very current in today, we hear about the flu, and everyone's sees in the papers anyway in WA, you need to go and get your vaccination for the flu because it's really bad this year. And when my son was 2.5 years old, I think, or 3 years old, I actually gave him a vaccination, or my husband and I decided to give him the vaccination for the SARS flu that was around at the time. Could that have been potentially a cause to the Tourette's? I have heard the name PANDAS, and I'm not sure if everyone is familiar with what PANDAS is, but I have read a little bit about it, although it was a few years ago. And so I'm just very concerned now whether to give my son another flu injection. So,
Yeah. Look, I think when we're talking about vaccination and injection, we always remember that, hallmark of a case about the link with autism and MMR vaccination, and it's been disproven so many times, but the damage that it's been done is done, and a lot of people question if the vaccination could somehow trigger autoimmune reaction in a vulnerable individual. And, maybe immunologists would be able to test that hypothesis, but in relation to PANDAS, it's not a very well validated diagnosis still. There is a lot of unanswered questions because, like, for example, one thing that I find frustrating is that none of the hospitals could agree on the panel, like lab panel, that everyone should use and put that issue to bed and say yeah or nay. So it's not at that stage. I think it's easier with PANDAS. It's harder with PANS, which is a more phenotypical description where, I think there is the serology for streptococcal is actually negative. So that makes it even less likely. But I'm very happy to give you the paper on the maternal history of autoimmune disease because it actually touches upon some of the questions you asked, and it looks at PANDAS. So I think maybe it would be worth read. But other than that, unless you see an immunologist, I don't think your question would be answered in full completeness, about the sensitivity to vaccinations. I mean, I could definitely not recommend you not to vaccinate your child. That is not what this is about. So, but I'm very happy to share some of the knowledge. Thank you.
Thank you. I really love seeing the collaboration of health professionals working the way you are, and you mentioned Westmead earlier because they work in a similar way and seeing all the parts. And I know from experience of having children that I had a neurologist that then referred me to a psychologist, and seeing how everything comes together is so important. And I can attest to that chart you had. I used something similar with my own son on he had rage and anger management, and whilst the first 3 nights it just got torn up and thrown away, that was enough to trigger his awareness. So I never think they're not focusing on it, and it really did improve. So it's the program you were showing was, I did it in such a small way, it wasn't so formalised. I couldn't get him into the psychologist's office because he also had defiance disorder, and get that in there as well, and it makes it a little bit tricky. So everything you were saying was brilliant, and if you can't even get your child into a psychologist's office, like I couldn't get him through the door, I was able to do this at home on a certain level, just as a layperson, so it's really fabulous. Thank you very much. We have lunch arrived outside. If anyone would like to ask questions, I'm sure that both Elissa and Yuria would be happy to answer a little bit over something like to eat, or unless you've got to run off. That's fantastic. Thank you very much. I'm glad you went over time. Unfortunately, Dr. Silva hasn't arrived, so we'll see what happens next, but we'll have lunch from 1 till 2 and we'll come back in and resume at 2. For those who are online and listening to me, we will resume the live stream at, I'll just see the time. The live streaming will resume at 2:45 with Thriving with ADHD and Lou Brown. Thank you.